Okay, actually, it seems like everyone's in the room, so wonderful. So welcome back, session 2. I'm really excited to have all of you back today. So what we're going to be talking about today is really that connection of the mental health team with the primary care team. And I just, I always like to say mental health is health, because a lot of times, we forget that part. But it is, we're very excited because we have Dr. Courtney Pladsen here today. So she is the Director of Clinical and Quality Improvement at the National Healthcare for the Homeless Council, and she'll be able to introduce herself once we jump in. So I'm just going to do a few housekeeping slides, and then all of you will get to hear from her. So this was from the first session. I just wanted to reiterate the same thing. The session is being recorded. The recording is going to be posted on the discussion board. We love all of you being present, being on camera if you can. We really appreciated that last time. It's always exciting to see people's faces because unfortunately we can't be together. So use the chat box as well as unmute yourself to ask questions. So just to let you know, Dr. Pladsen will be presenting different examples, and then in between that, we'll have time to ask questions. So if any questions come in during that time, either myself or Mariah will be able to field her. Again, if you have any issues, please let Mariah know. She's able to help you. We seem to have worked out all of our technical difficulties from before, but if for some reason you can't reach Mariah, you could just send me a message as well. And we would greatly appreciate filling out the evaluation at the end of the session. That always really helps us. So, we really want this to be what all of you are looking for. And then I do want to just remind everyone, we do have the discussion board. So you should have a login. If for some reason you did not receive that in your email, one thing I would suggest first, check your spam email just in case. But if not, go ahead and contact Mariah. And if you do have technical difficulties with the discussion board, Mariah is also able to help you. So this is where we put all of the PowerPoint after the session is done, our recordings, our resources, as well as the assignments that you will be doing for the following session. And then you can also ask questions and communicate in the discussion board. So I check it pretty regularly, but all of you will also get notices when people post. And I believe it was Deborah who posted already on the discussion board, so really appreciate that, and you can talk to your colleagues. Learning objectives, outcomes, still the same. The focus is looking at mental health providers, how we can recruit them, how we can retain them, because as I said, this is Recruitment Boot Camp, but it can't be separated from the retention part. Just an invaluable role as part of the healthcare center's primary care team, and that's what really today's session is going to focus on. And as we go through all of our sessions, by the end of it, being able to create your comprehensive workforce plan. And I see people have put on the chat, so just give me 1 second. I just want to make sure if there are any questions.
No, I just asked people to share.
Yeah, everyone is saying hi, and then I know somebody was unable to connect. So welcome, Maxine. I'm glad that you were able to connect, and perfect. Welcome, everyone. I just wanted to make sure I didn't, miss any questions we went through. So my last slide that I'm going to go into, I always want to leave just a little bit of time to see if anybody had any questions about the homework assignment. So I want to be here to answer any questions you may have. If you have not accessed that, again, it's going to be on the discussion board. And really the focus was on being able to assess what turnover is costing you versus what retention costs. And having that difference, because most likely, I would say 99% of the time, turnover is going to be way more expensive than what you put into for your retention plans. And this is also a great way to talk to leadership about why this is so important. So if anybody has any questions, I'm just going to give people like a little bit of time just to kind of put their thoughts together before I turn it over to Dr. Pladsen. But please put it in the chat or unmute yourself now. And of course, if you have questions any other time, you can always email me as well. anything. So I may just go ahead and stop sharing. One other thing, I did have a few of you email me your job announcements to get that one-on-one feedback. So if you're interested, please go ahead, still email it to me, and I will definitely get back to you prior to session 3, because that's when we're going to talk about advertising and social media. Okay, so not hearing or seeing any questions, I'm going to go ahead then and pass it to Dr. Platson.
Thanks, and please call me Courtney Michelle. I appreciate it.
Courtney, I always do that.
It is really a pleasure to be with all of you this afternoon. I am based in Portland, Maine. Feels really random when I meet with people all across the country because the National Healthcare for the Homeless Council is based in Nashville, but I work 1 day a week in my local Healthcare for the Homeless program here in Portland, and then I work at the council the rest of the week. We're going to be diving into integrating behavioral health and primary care. And what I'm hoping to do is to give some background into the why, which I know you know, but I really want to underscore some of the specific aspects of the why, and then I want to walk through a few examples of retention, recruitment, and then one example of a really innovative program. So I really want to make sure that providing kind of a few different examples for you all for this afternoon. After each example, because I'm going to spend a few minutes on each, I am going to break up the conversation for questions. So I want to make sure that for each example, we have some time to have a conversation. So feel free to add any questions into the chat throughout. I'm happy to answer them if you have any specific questions on any slide. But otherwise, we'll go through the examples and then we'll have a conversation in between each. Because each of them are very different. So I want to make sure that folks have a time to respond. So we're going to talk a little bit about identifying the importance of integrating behavioral health. We're going to work to describe 2 strategies to adjust recruitment and retention, and then discover a different program model, identify ways that you might be able to replicate it in your own health center. So I know that this is what you all are seeing. You all are experts in this field as well, but I just wanted to underscore the immense burden that is happening and is continuing to grow. So we know that as many as 40% of all patients seen in primary care have mental illness, have been diagnosed with mental illness, but that's even more in healthcare for the homeless organizations of federally qualified health centers that have HDH grantees. That portion is even higher. We know that 25% of all Americans at some time in their lifetime will struggle with substance use disorder. And so for that reason, we need to make sure that we're having access to substance use treatment across the lifespan, and making sure that when people are ready for treatment, need treatment, that we're able to provide that. 80% of patients with behavioral health concerns present to the ED or primary care. So we know that often that stomach ache, that what people feel is shortness of breath, it can be anxiety, it can be depression, it can show up that chronic pain might be really have a mental health underlying component. So it's really important to be able to meet people, receive them, affirm them in what they're experiencing, but also provide the appropriate care. Because if I'm only prescribing something for their stomach, we're really never going to get to the heart of the problem. So making sure that we are offering really the full scope of services our clients need. Approximately 67% of patients with behavioral health disorders do not receive the care they need. And so this is what we are missing. SQHCs really lead in this space. You all are doing an incredible job at integrating. We've been on this journey for many years now at integration, but we still know that there is so much more that is not being addressed. And so recruitment, retention, and building out our staff and really fully integrating it is absolutely necessary to meet the need. We know that the pandemic has only exacerbated the need as well, and limited resources and widened that gap. And 68% of adults with mental disorders have comorbid chronic health disorders, and 29% of adults with chronic health disorders have mental health disorders. So it's no longer sufficient to silo. We have to be able to treat mental health and chronic health conditions together because they're so inextricably linked. So I want to kind of focus for a moment on substance use disorder services, because the wonderful thing is that health centers have really met this need uniquely compared to other primary care settings. So we see that substance use treatment services has increased 108% from 2016 to 2020. But in 2020 we saw was a record year for overdose deaths. So we're doing better, we're growing out discomfort, we're doing in-service training, we're integrating our behavioral health and primary care, we're prescribing more Suboxone, we're doing more screening, but people are still overdosing, people are still dying. And so the need continues to grow. And again, this past year, it's just amazing that the need continues to, the severity is growing. And then since 2016, the percent of patients screened for depression with a documented follow-up plan increased from 60 to 64%. So we see that we are moving the needle in screening and addressing depression. And then the other amazing work that has happened is that 13% of patients with major depression has reached remission. So that's pretty incredible thing that the need was screened, addressed, and that person actually achieved remission from depression. And then we see that mental health patients increased from 40% from 2016 to 2020, over 2.5 million people. So really amazing growth. We're doing a great job. We're moving in the right direction, but the need is still there. So doing great work, but we have more to do. All right, and this is what we're working towards. So this is the goal, right? So the goal is to meet clients where they are. So we want to take harm reduction model out of just substance use. We want to really incorporate that across primary care, saying we are here to provide holistic, compassionate healthcare that includes all of the things. That's the holistic care. We are here to do your cancer screening. We're here to treat your blood pressure, here to talk about your mental health and well-being, here to talk about your substance use, and meet people wherever they are along that spectrum, depending upon their readiness, their goals, and how we can support them. But one of the things that's really special about integration is the one-stop shop and really reduce stigma. So people can see their PCP and see their social worker, who they might be seeing for case management or not even addressing their mental health. But then there's that day that they open up or something changed. They got served an eviction or they lost a loved one. And they have that relationship. They have that ability to come in and talk. And then that might create a door where people can finally have that conversation about what they've been experiencing with their mental health. So just some of those relationships that can be built in primary care are so special for being able to have people have a space where they feel comfortable when they're ready and want to share and start talking about their mental health. One of the other things for people that really don't identify with their mental illness or struggle with paranoia or really have had a lot of maltreatment in institutions in the past, some folks really struggle to see psychiatry because of a lot of harm that's been done in the past. And so often by having a place that has integrated health, behavioral health, it might be a building block for being able to feel comfortable in primary care first, meeting with peer support, building that trusting relationship, meeting with the social worker to start addressing some of their immediate needs. And then over time, that might create comfort to be able to address their psychiatric needs as well. So the importance of having this as a team-based approach is just so incredibly important and impactful. And it really lives the triple aim of improving patient experience of care, improving population health, and then reducing healthcare costs. All right, so we're going to get into some different models. So first, we're going to go to Greater Portland Health. So that's where I work. That's here in Portland, Maine. We're going to walk through a scenario of struggle with recruitment. So a couple of years ago, this was in 2019 now, we had our program was much smaller. We had a smaller team back then. We had the same licensed clinical social for 12 years. He was the institution at our health center. We had providers come and go, we had other staff, but the social worker, Bill, everyone in the community knew, and he was fantastic. The clients loved him. We had our same social work director for 8 years in the community. So Molly was only at our health center 1 or 2 days a week, but still everyone knew her. So the two of them were so well known and loved. And then the same year, Bill retired, and then Molly ended up leaving because of a medical condition that was an emergent issue. So she ended up just leaving, and we were left with no social workers at our healthcare for the homeless clinic. So we had no behavioral health team, we had no succession plan, and we had no pipeline because we had these institutions in place who were fantastic. But we never thought, what if they leave? What if something happens? What do we do next? We weren't training anybody. We weren't doing any cross training with other sites. And so we were left up a creek, and we have full primary care service. We had at the time a daily dosing Suboxone program, and now we had no licensed clinical social workers. So we were really struggling. So this is our substance use treatment program for our opioid use disorder program. So this is who is supposed to be on our team. Me as the primary care provider, we had RN, a medical assistant, a peer support, licensed clinical social worker, and a case manager. Our social workers left. Our peer support quit. Our case manager quit because it was a domino effect, right? It was like, they're gone, everyone took on this massive load, everyone was super overwhelmed, and then we had no structure. And so it was challenging, to say the least. All right, how we picked up the pieces. So we recruited, we had one social worker that we hired. She did not have supervising expertise. So she was hired not as our director and not as a supervisor, but as a social worker. So she's a brand new social worker. She had a social work experience, but new to us. So she had never known our team, but had never done integrated behavioral health before. Thanks, Lydia. And so she had never worked in a federally qualified health center. So she was not familiar at all with the integration. So she worked in a jail previously with incarcerated women doing individual therapy. So her passion was individual therapy. And we work at a healthcare for the homeless clinic where most people aren't doing individual therapy, and it's a lot of crisis management and walk-in. So what we had to do was help integrate her into our team. So we had to actually do a lot of training, which we had not done before because Bill and Molly got it because they were always a part of our team. So we had to be really intentional. We had to then also create a pipeline. So Molly, our new social worker, started taking on students. So she built relationships with our local universities to then start having a regular rotation of social work students. And then we had to make a shift about being intentional about learners being part of the team. So we didn't want this person to just be cast aside. We really wanted them to be embraced and be able to understand the culture of our health center, understand the culture of integrated behavioral health, which is different than a lot of their other placement and training. We want to develop an atmosphere of continual learning. That way these new providers, new learners can come and ask a lot of questions and know that not everyone is just a part of the institution. We are all here to learn, no bad questions. We had to create partnerships to fill in the gaps. So we had to bring other social workers from other health centers to cross-train them. There was a lot of fear and stigma, even within the same organization. Someone coming from a health center to working in healthcare for the homeless. They were scared to come to our neighborhood. They're scared to work with people with severe persistent mental illness. They're scared to work with people who use drugs. So at first it was shocking. We were like, they're right down the street. There are other health centers. How is this a challenge for them? We were really surprised that was the barrier, but we had to create these partnerships, and we were better off because of it. So now, 3 years later, folks, when they need to come and cover, they understand our health centers. We realized that we had to have cross-organizational training. We had to have people be able to come and understand what the other health centers do and how to do it well. And then intensive supervision. So in the beginning, when Molly was new, it required supervision with not only her social work supervisor, but also the medical director. That way we can really be intentional about how do we intentionally have this integration. Again, she's coming not from an integrated model. So she was not familiar with warm handoffs. She's not used to people asking her to fill in crises. Wasn't used to, she was really struggled with being what she would say the bouncer when people had behavioral health challenges. And so we really had to help usher in a culture shift around how do we work together in this space as an integrated team. So here was part of our process and our intention. So initially, our social workers were in a different area. We decided we need to co-locate our staff. We need to be able to have not medical versus behavioral health. We had to sit together. And that really helped I come back from a patient room. I don't know what to do. I'm asking questions. And we as a team are coming up with treatment plans. Oh, let me call this person. I had a no-show. Let me go in and talk to them. It really helps to facilitate warm handoffs. And team building, because we are in conversation regularly. We can support each other, we can vent to each other, but just to co-locate, there's a lot of soft skills and soft cultural change that happened by that having that shift. Communication, we delineated time for case reviews. So to really focus on how do we work together, we would present cases. So there's a time once a month that we review our patients in our substance use treatment program. And then there's time that we just present anyone that we're struggling with in particular. And anyone can present a case, whether it's a social worker or a primary care team. But just having that time together was really helpful. It's again, problem solving, but then also saying, oh, we each bring expertise to this table and this client needs both of us. So that was really affirming of this partnership. And then routine staff meetings all together with all interdisciplinary teams. And then we would break out one time a month, we'd have the whole team. And then once a month, we break out by department. So nursing would get together, the providers would get together, behavioral health team would get together. So we want to respect and know that everyone has some continuing education or things that they need to work on as a department. But then also we want to make sure that we're acknowledging the unique nature of a multidisciplinary team and carving out time for that. And then level setting. So one of the things that happened initially, I think, and this is, I think, a struggle in medicine in general, is we have a lot of hierarchies. And there was some feelings initially that the primary care team and the primary care providers were the ones really, people were being very different, what's the word? People were treating the providers as if they're better than the social workers. And clearly that's not the case. And clearly we need everybody at the table. And so part of what we did is we created space at our multidisciplinary team meetings for the behavioral health team to lead some of the trainings. They have all this expertise that when I went to nursing school or got my NP or doctorate, I did not learn the same things as they did. We wanted to create the space for them to share their expertise and to let the rest of the clinical staff know, our medical assistants, our peer supports, that de-escalation or trauma-informed care are some of their skill sets. So let them lead these trainings. And that really helped the rest of the team to understand their skill set. We let them always lead our grounding exercises. We acknowledge once a month in our team meeting, we go through who had passed away that month or who overdosed that month. And we always let the behavioral health team lead us in that space and acknowledge that mental well-being is part of what we need to do to care for ourselves as a team, and they're uniquely experts in helping to promote that. So we want them to lead in that space, and then acknowledge and appreciate their contribution to the team. So this was really important too, is saying, we need you all, you're doing a great job, and just literally provide some affirmation. So the pipeline was really important. So Molly came, thank God for Molly. She started right before the pandemic. Helped to usher in some students. We were able to have every semester new students rotate through. We also paired that with more nursing students rotating through too, because that we realized, oh, our nurse who's 62 years old may also retire at some point soon. We do not want the same thing to happen where we have one nurse and a whole program built on one nurse. So we wanted to do the same. This is important for our community in general. It'll help people understand what is unique about FQHCs, healthcare for the homeless, and these integrated models. And so we really started to promote, again, as a culture of education and ongoing learning. And then that pipeline has helped to bring on other people. And they have conditional licenses as LCSWs, but we've decided that that was really helpful, that they already have trained with us. We know them well, they know our system. So that's really helped to create a pipeline for our staffing. And then these other pieces have really helped us as a team to become integrated as they've come on board. So just want to pause there to see if there's any questions specifically about what we experienced, what we went through, anything that you're curious about, questions, thoughts.
Hi, my name is Kevin Miner. I am the Addictions and Integrated Behavioral Health Manager from Multnomah County in Portland, Oregon. What I've been noticing, and maybe you've experienced this as well, is that as integrated behavioral health becomes more and more of something that is kind of taught and understood within education and kind of master's and doctorate programs, I'm noticing that more and more individuals are wanting to connect with agencies or entities that really hold that integrated behavioral health fidelity very well. And then what I'm noticing in our clinics and really in the state of Oregon as a whole, it's very hard to hold the integrated behavioral health model in its fidelity when there are so many traditional mental health issues that we need to address or most effectively addressed in a kind of more traditionally mental health treatment plan, 45-minute, 60-minute sessions. And as we're recruiting and we're kind of having that conversation that it's really more of a hybrid because we don't have co-located mental health and the agencies in the community are about a 3 to 4 month waiting list, that really turns off a lot of individuals, and they kind of go more towards a system that has a very clear, this is integrated behavioral health and this is, behavioral health or mental health, and you may coordinate together, but you don't do the same thing. Are you noticing that, and do you have any way to kind of address that issue?
That's such an interesting point, because people now are seeing that, oh, that is the gold standard, and that's what I actually that's what I want to find. So it sounds like I want to ask a few clarifying questions. So in the model that you have, are they not being able to, does your behavioral health staff not have the individual therapy time? I wasn't quite following what you were saying in terms of you don't provide the specific model.
Sure. So we, our goal obviously is to provide integrated behavioral health in its most, in its most known way and way it should be practiced. And so, and the templates are created that way, the workflow is created that way, but we don't have the ability like some mental health programs to say, our caseload is enough. We can't take them. We're a federal qualified health center, so we can't turn individuals away if they come in and need that assistance. So what ends up happening is, either we become, we wear 2 hats and we become mental health clinicians in the sense of we're really working with someone with complex mental health issues or long-standing trauma. And normally we would say, okay, we're gonna, help you and then get you a referral to an outside agency, but our outside agencies are maxed out completely. And so then it becomes a situation in which we're again kind of doing that hybrid model, or we're bridging somebody for 3 to 4 months, which again just becomes a situation. So it's taking away from, the sort of understood amount of visits that we should have and kind of our budget is done. And it's not necessarily, we're not able to necessarily show, hey, we're doing integrated behavioral health, but we're also doing mental health. So you may not see that we have as many visits as we normally have had, or as many warm handoffs, but we are making a pretty big impact with the individuals that we have to see, in some cases for over 20 sessions.
That's so interesting. So yes, that actually makes sense. So we struggle with that too, where people really need like ACT level of care. Like we're not the ACT team, but they really need that. One of the next examples I'm going to share talks a little bit about how they delineated their roles into half of their social work team is crisis management and case management, and the other half is providing longitudinal individual therapy. And that has been an interesting way for them to try to meet that crisis in the moment need. But then if someone is actually engaging more long-term, they do a warm handoff to the behavioral health therapist. So I'm curious if your team has tried to delineate a little bit in terms of maybe who is providing that crisis or upfront case management for people with really severe persistent mental illness, and then being able to do any kind of handoff to other folks that are having a specific caseload.
Yeah, I mean, that would be fantastic. Again, we don't have the individuals that, have that specific caseload or title. And so really what occurs is, we do a lot of triage. We handle usually I'm handling the crisis situations and sort of we use an Epic Chat EMR. And so I kind of do 911 stuff throughout the day on that. I think the biggest issue is, 2 things is one, obviously we're not able to fully meet our patients' needs within this model. So we have to kind of switch the model around to meet our patients' needs. And then this only further kind of confuses the providers around like, what our role actually is. And there's a lot of other issues kind of, specific to Oregon that don't necessarily apply here, but the overall problem is that they're, like you noted, like, if I'm working in a hospital system that has a very clear, this is the behavioral health service and this is the integrated behavioral health service, we don't necessarily have that. And so we're discussing and thinking about how we can create some level of funding source or wrap payments around using traditional mental health and hiring. But at the same time, then, I would probably need about maybe 4 to 6 LCSWs, and they're nowhere to be found in Oregon. So,
And,
Yeah.
Courtney, do you mind if I jump in?
Please, I was going to ask if there's anyone else.
Yeah. So, Kevin, we actually had a similar scenario in the first recruitment boot camp we did, where someone was talking about that and the difficulty of recruiting people, but then retaining people when the model that's followed is not what they were expecting or what they prefer. So what that health center did was make it, and maybe you're doing this already, but one of the suggestions that was made was starting way from the beginning, already from that job announcement, making it super clear of what the model is going to be. And I'm seeing from your head nodding like you may already be doing that, which
been there.
Right, which of course then makes it difficult because you're like, nobody's applying for that. The other thing that I'm trying to remember what health center it was, but basically they created better pipelines with the local schools that were really focused on that integration model, but they went even outside of their state to recruit into the neighboring states. That basically they did an assessment of what are the schools that really are teaching these type of models, which is something that, and I know that takes time as well, but they were able to make connections to bring in students to do their supervision, their internships, everything in the health center, so that they already knew the model that they were coming in to recruit them later. But I also would take into account, if that's something that you're interested in, think about all of the online schools that offer, social work, nurse practitioner, counseling degrees, because a lot of them do have that integration model. I know for me, when I did my doctorate of social work at USC, that's exactly what it was. It was all about an integration model. So there are a lot of places out there that I think are trying to teach that even more. In fact, the nurse practitioners program is in the social work school at USC for that purpose specifically. So I would say that may be a good place to go. And even from the putting it in the job announcements, when people come in to interview, reinforce that, just keep reinforcing it, because what they found, when I was talking to this other health center was, yeah, we had that in there, we reinforced it, people were like, yep, everything's fine, and then they would leave as soon as they realized that's not exactly what they wanted. So the more that they could have people train in the health center actually improves that retention component.
Yeah, that's super helpful. We do have a SID and a MSW student at this time. What I've noticed, and I totally agree with that in terms of the transparency and really giving them an understanding of what we're, and that kind of does somewhat have a reverse effect in the sense, as you noted, it does sort of like eliminate the hope that we may get this individual because they leave after that. And as you noted, there are more specific programs now, and that's great. At the same time, they also note that, this is what I want to do, and I can get this at, this, but you give more of a hybrid. So, we really focus on looking for, honestly, LCSWs. They're not quite like in that unicorn format where they're like, we like mental health, but we also like working in a health center. But, that we seem to, have more flexibility with their role than I've experienced with PsyD. And I think that's just partly because of the education and the experiences they have within the thing. Sorry, I don't want to take up all the time, but I really appreciate your feedback.
No, absolutely. And one other quick thing was, and Maxine, I think she put a similar comment in there, but don't also overlook who is in your health center, because sometimes someone who starts in case management may want to move to some of these other positions, do more integration, but we just don't know because we don't ask. So we think that they're leaving because those models aren't there, but they're actually leaving because they're like, oh, why wasn't I moved to this or that? So that was the other comment I just wanted to make.
In Maine, even before the pandemic, we always had a hard time recruiting credentialed staff. We just don't have, we have like one social work school, for the whole state, there's like one law school, one medical school, because it's such a small state. So two of our last social workers and our clinical director were all recruited from other states. So it's super challenging. So I definitely feel that.
Well, I'm in New York, Westchester County, and we do have social work schools here. And I think sometimes what happens is, again, you have organizations where individuals are so entrenched in their past and how things used to work, they're not moving forward into what's available right now. I had brought up I'm retired and got bored and came back to work to keep my brain active after 25 years in administration. So coming back, I'm saying, why don't you have students here? They're the future, and you're recruiting staff when you have individuals, and people were looking at me like I'm crazy. So now I finally, got the ear to get a Fordham student in here that's going to start in January. And it's like, when you approach people, it's like, oh, it's more work. I'm going to have to take time out of my day to supervise them. Another issue is the pay for social workers for licensed individuals coming out. And that's a big issue. And one of the things is that you look at individuals who have claimed to be, quote, social workers and do not have degrees. Mm. And then, they get into these positions, well, I'm a social worker. And then when you start asking and looking at resumes and looking at really credentialing, you find out that these individuals do not have the credentialing to actually be in the profession and to be seen as social workers. So those are some of the issues that I know that I have encountered, and looking back and seeing who's who that's on the board.
Thanks for sharing, Maxine. I also think one thing that we finally started doing was interviewing as a team, a multidisciplinary team too. So we can introduce all of ourselves and explain how we work together. And so folks can understand they're not just signing up to work in one department, but also as a team. So that was helpful for us. All right, we're going to get into the next example. So I'm going to dive into Colorado Coalition for the Homeless. There we go. So one of the things that they were really struggling with was staff burnout. And they're trying to be all things to all people. And we know that this happens all the time with our social work staff. So this is what one of the social workers said: I can't be expected to be a bouncer one moment and an individual therapy session the next. It's just too much. But this is what they were struggling with, because they were expected to do behavioral management, crisis intervention, but then also have scheduled appointments. And so that was really, people were leaving, blocking. So one of the things that they did is that they received a grant in Colorado to integrate. So part of what they did was that they started to coordinate care. So the behavioral health services were by referral at separate location with formal information exchange process. So that's how it was set up. And then they really instituted routine screening for behavioral health and primary care. So doing the depression screening, doing anxiety screening, screening for substance use disorders, and creating very specific referral pathways between behavioral health and PCPs. They had routine exchange of information between treatment settings, and then PCP delivers behavioral health interventions and following algorithms. So they really tried to integrate, create screening tools, create pathways, and routine exchange of information and communication settings. So, this is coordinated care. So this is when they were at separate locations with formal relationships. This was co-located care. This is when the behavioral health care is available by referral at the same location. They had the medical and mental health facility in the same place. You can refer from mental health from PCP to mental health specialist, and they had enhanced informal communication between providers. So that's really, again, that warm handoff in the moment between patients. And then the consultation. So PCP sees a patient identifies that they either in mental health crisis or they really have an acute need, and that's where the mental health clinician can be brought in. So moving from coordinated care to co-located care. And then this is where they end up in the integrated care. So behavioral health consultants are working in primary care as part of the team. So again, in that same room. So really that treatment room, they showed the picture, primary care providers, mental health team, all in the same space, one facility, one treatment plan with behavioral health and medical elements, and an interdisciplinary team working together to deliver care. So this is much more, those are kind of the 3 iterations where they moved from to where they are now. And this is just showing the progression. We're not going to get into each aspects of this, but the 4-quadrant clinical integration model, just wanted to have that here as a resource. And again, this is another resource. This is what, I can't remember her name, but the director of social work shared this with me, and just as a quality of successful integrated providers. I thought this is just interesting to be able to read into. We're not going to read every square, but really looking at what are the skills of the providers that we're looking for integrated clinical practice skills, practice management, consultation, documentation, and team performance skills. And so I think one of the things I just wanted to highlight, though, is the team performance skills. So understanding and operating comfortably with primary care culture. So really increasing the comfort with understanding what happens in primary care, what is the scope of services, understanding who the providers are, and that they are an essential part of that primary care team. Showing awareness of team roles, like what does the nurse do, what is the community health worker, what are all these different components of these teams. Readily provides unscheduled services when needed. So this is really tricky for some folks. This is a shift when people are in the integration. So, a lot of people go from individual therapy where it's very structured, and in primary care, you get thrown curveballs all the time. We see people, especially, FQHCs, community health centers, if there is a sick person or someone in crisis, I'm always going to try to squeeze someone in, right? And so that might not be within the comfort zone. So that's where what you were sharing, Michelle, I think is a really important point about some of the transparency of how the model works. Some people love that philosophy. For some people, it's really, I think of the difference. I used to work in the emergency department, but it's the difference for providers who work in the ICU versus the ER. The ER, you're always used to juggling things. You have a code come in, you have these 4 other patients, people are coming and going, and you're used to the organized chaos. People that work in ICUs, they have their 2 patients, highly regimented, everything's planned, they have a million drips. You want them to be detail oriented. They do not like curveballs, right? So who are you recruiting for that position? We need someone that can juggle. We need someone that can provide that unscheduled service, jump in, want warm handoffs, really be able to jump in with that team. So this is where I think it's really interesting. So they have a suite model. They have the 3 different suites of integrated care teams, but their behavioral health team has 2 different types of providers, 2 different types of social workers. So they have 3 LCSWs, but one is identified as a behavioral health provider and one is a behavioral health therapist. So this is what I was saying, where they provide different range of services. So the behavioral health provider provides crisis intervention, case management. They might meet that person, for the first time or when someone comes in crisis. They have flexible schedules all day. They go with the flow. They might see that person 2 or 3 more times. But once that person gets to a 4th visit, they hand them off to the behavioral health therapist to provide that longitudinal support. And so this has been a really successful model for them because they were really struggling to retain providers. And again, it was I can't be all things to all people. And some people really love the therapist role. They love seeing people, long-term relationships, delving into that complex trauma, working on therapy, many sessions, months over time. And some people do not like that at all. They really like to go with the flow, deal with crisis in the moment, and that fits their skill set. They like more case management. And so I think trying to identify the needs of each role and hiring and recruiting people for that specific role has been really incredibly helpful for them. And so you can see the behavioral health therapists function more like traditional community mental health center therapists. And then the behavioral health providers are really much more the walk-in. Thoughts about that model? Questions? Has anyone seen those roles before? We're delineating between behavioral health providers and therapists and doing more crisis management first therapy.
Yes, and honestly, in my opinion, it's the only way that integrated behavioral health really keeps its fidelity and works. Yeah, that's my opinion.
Yeah, we did not have that before, and our therapists were so frustrated and overwhelmed. I mean, to go from a case management to individual therapy is really, it's too much for people, and it's a really different skill set and a different headspace. Another thing that's important is what is a billable encounter. That's a good point, Maxine.
And I would also add, like in terms of retention, you also are going to retain both of those clinicians much more, because I think one thing that's overlooked when we don't have that sort of ability to warm handoff to another individual that has a skill set or has the resources to help them, is that really impacts the clinician, in the sense that they really feel like, I can't help this individual based on the system that I'm working in, and that can be really detrimental as well.
I think that's such a good point. Thanks for saying that. Yeah, and I know for myself that's the case. It's really exceptionally overwhelming when you know someone is in crisis and you're not able to meet their mental health needs. And it is, yeah, it really drives a lot of burnout for primary care providers too. So we really depend on each other. Looking at the chat. Yeah. All right, so we're going to quickly, I know it's 3:47. I'm going to dive into our last model. So I wanted to share, and maybe some folks are aware of this, but we wanted to share the Cahoots model. So they're out of Eugene, Oregon, sorry. The Whitebird Clinic is in Eugene, Oregon, and they have a really unique model that I wanted to delve into. So this is just a little bit about their program, but they have been around for a long time. They started in the 70s as an ambulatory free clinic, providing medical care and crisis intervention. And then in the 90s, started a specific crisis intervention program in partnership with their local police department as a way to divert people from just getting arrested or having police respond to mental health or substance use crisis. And so this is just, it's amazing because it's something we're talking about now in 2021, but they've been doing this for a really long time. So this is the range of their services. And what I think is absolutely amazing to me is, look, medical and dental are like one tiny sliver of all of these other range of services that are all across the mental health and behavioral health space. So they have crisis, they have counseling, they have Chrysalis, Cahoots, the specific case management for the homeless, and then service front rooms gateway program that helps get people connected to health insurance and other community benefits. So this to me is really interesting because they provide whole, integrated behavioral health, but they also really have a multidisciplinary behavioral health team that provides a full range of services. So it's, and because of that, they're able to provide some unique models. Even at a community health center, they have this crisis emergency response 24/7. And I'm going to show you, we're going to dive into that a little bit more, but I thought that this was really interesting. And their priorities to serve people who are unserved, underinsured, disabled, and or homeless. So really try to catch folks that are not being served by any other programs. So I think that's really part of why they have really a mental health focus. So they have a crisis program. So they have 24 response for anyone in crisis. So they have a phone hotline and then a walk-in crisis counseling. So the center is an entry point to the Lane County mental health system, providing mental health screening, information, and referral to community mental health and counseling services. It's also the screening center for special transportation services for the mentally disabled, and crisis service are open to individuals, couples, families, and groups. So that is really an amazing resource. They provide individual counseling, traditional counseling for folks. The Chrysalis program is really fascinating. It's a client-centered humanistic treatment program for substance use disorders, the full range, and they do acupuncture and Reiki and all these other wonderful holistic services, in addition to providing traditional medication for opioid use disorder and other substance use disorders. So they provide education courses, counseling, but they really provide some really holistic care as well, which is just wonderful. And the Cahoots model is the one I wanted to highlight, and I'm going to just show a really brief video about it. So CAHOOT stands for Crisis Assistance Helping Out on the Street. So they provide mobile crisis intervention within the city limits of Eugene, and they are dispatched through the Eugene Police Fire Ambulance Communication Center. So when someone calls 911 for having a mental health emergency, it's a nurse or an EMT that's on the van with a crisis worker, and they are an experienced crisis worker. So this isn't, you know, someone just graduating. So I just wanted to show really quickly this video. Let's see if we can get this to work, and let me know if you all, once this loads, if you can hear it. Oh no. Are you hearing this?
No, the audio is not playing.
Okay, that's okay. I will send this clip to Michelle so she can share it with all of you. But just so you can see, they go out on a van and they go out with the EMS provider and a crisis worker, and they meet people out on the street wherever they are in connection with their, they don't have a response from the police department. They're the ones that respond. And so this has been fantastic for reducing people getting incarcerated and then connecting people to mental health and substance use treatment programs. So that's one of the things that it's just been, they've been doing this for a really long time and have had a lot of success. And what we're seeing is a lot of other people really in this racial justice movement saying why we need to defund the police and put more money to mental health. This is one model that works really well that can be health-centered driven, that really is an extension of some of the work that we all are doing. And it's a really unique way to be able to meet people where they are on the street in crisis and move them into the services of comprehensive care at the health center. So I know we only have a few more minutes, but I just wanted to, I know we breezed past the CAHOOT program and all the great work that they're doing, the Eugene program, but just wanted to see if people had any response to that, any thoughts or questions. Have people heard of that program before?
So I know it's a typical white male to dominate everything, and I apologize, but I grew up in Eugene, so I'm very familiar with that program. And you know what's extremely helpful of that program, because they have something similar in Portland called Project Respond. But what's very helpful about that program is one, well, just how visible they are. Like, you know when that individual is coming and you know what that individual brings. And so that really gets around the community, and law enforcement buys into that and fire department buys into that. But when an individual sees that, you know, versus, you know, flashing lights or something of that nature, it really does mean something. And so I think that that's something that I think you can't necessarily just start out with. It historically has to kind of be built within the community, but that's something they've done very, very well.
So a lot of relationship building, it sounds like, and really planting seeds over time. Yeah, I don't think that that can happen overnight. I think you're absolutely right, because they've gained trust from both the police department, fire department, emergency response, and from community members and people that they serve. And that takes a lot of bridge building. So I know we covered 3 different models, talked a little bit about recruitment, retention, and another extension of a healthcare, of an integrated model into the community. Do folks have any thoughts, questions? What else do we want to cover? I think Lydia and Michelle, you're having great points. One of the things, we're all struggling with staffing issues, right? And so we're struggling to recruit medical assistants. And so we said there's no medical assistants to hire. So we transitioned that to what's called the clinical team assistant. So it's someone that doesn't have formal training, but we realized that they can room people and they can do the documentation. And so starting to get creative about how do we become expansive as possible within these roles? What can we train? How can we train a staff to be their peer supports, hire people with lived experience? How do we recruit and retain community health workers to fill in some of these gaps around case management? And so I definitely agree that we might not have social workers, licensed clinical social workers to be able to hire right now, but how can we create really expansive multidisciplinary teams to try to fill in the gaps in the meantime and get creative with those positions as much as we're able. Does anyone else want to share any other examples that that have worked well for you? I know you all come here with a lot of expertise yourselves as well.
And I was going to jump in and say that, you know, all of you are bringing a lot of expertise, and really it's that collaboration with each other. But it is really important sometimes to just get creative, like who else can do these type of roles? You know, does a certain training in the health center help them achieve what you were looking for? Like, can those gaps be filled in that way? And just in general, with the shortages being there, you know, this is across the board, just with all type of providers. So that creativity, you know, is very helpful.
Well, I really appreciate all of your thoughts and sharing your ideas in the chat and your questions. It's been really a pleasure to be with you all this afternoon. Michelle, I will turn it back over to you.
It's great being with you also. It was a very informative presentation and I learned a lot, and I'm going to go on the resource board and pull up some of this stuff.
Wonderful. I'm glad to hear that, Maxine.
So yeah, we will have, as I said, we'll have all the PowerPoints posted, the recording and everything like that. So I was trying to like simultaneously answer the chats as well while everybody was talking. So, but I want to also just say thank you. And thank you so much, Courtney. This was a wonderful presentation. Our next one is going to be November 10th. And we're going to be focused on talking about advertising, social media. And I just want to double check advertising, social media, as well as how do you build out a recruitment team that includes behavioral health in it. Okay. And I believe Mariah will have like a short evaluation for all of you that we will send you. Oh, there it is. Okay, it just popped up. So if you could fill that out, that would be wonderful, and I greatly appreciate it. And I hope everyone has a wonderful day. Again, thank you, Courtney.